Dr. Chidinma Ibe is an assistant professor of medicine at the Johns Hopkins University School of Medicine and associate director for stakeholder engagement at the Johns Hopkins Center for Health Equity. She received her bachelor's from the University of Pennsylvania and her doctorate from the Johns Hopkins Bloomberg School of Public Health. Dr. Ibe has presented about advancing health equity at hospitals, at the Bloomberg Health Summit, and published on topics including global innovation for community engagement in healthcare, co-developing community and academic partnerships, and patient activation, intervention, and medical visit communication, among other health equity-related topics. Dr. Ibe, the floor is yours.
Thank you so much. And I actually do have some slides about the Center for Health Equity, so I can share them with you all at this time, but also answer any questions you may have about the Center for Health Equity, the book, and how it relates to the work that you're doing. Before I begin, may I just get a sense of who all is here and present and what your backgrounds are?
Absolutely. So we have a lovely cohort of researchers, clinicians, academics, and I believe some people also work in community health. If I miss anyone, please type it in the chat and I'd be happy to say that aloud. But if not, that's pretty much what we have in the room right now.
Awesome. Well, I'm really happy to be here with you all. And again, I do apologize for my mistake around when we would be meeting. So please, again, accept my sincerest apologies. I wanted to share just a few slides with you all about the Center for Health Equity. It's only about 8 slides, just to give you a little bit of background about what the Center for Health Equity has been trying to do over the past several years. We celebrated our 10-year anniversary 2 years ago, so it's exciting to see what has transpired in the last 12 years. And the Center for Health Equity is led by Dr. Lisa Cooper, who is the author of the book, Why Are Health Disparities Everyone's Problem? So the mission of the Center for Health Equity is to promote equity in health for socially at-risk populations. And we're trying to achieve this through 3 overarching aims. The first is to advance through advancing scientific knowledge. The second is educating and training leaders. And the third is partnering with communities. And in terms of partnering with communities, one of the main things that we are trying to do through our community advisory board, as well as individual and collective projects underway throughout the center, is to raise public awareness of health inequities and promote sustainable changes in practice and policy. So I'll give you a tiny example of that. A lot of the research that I do focuses on the role that community health workers play in supporting health and well-being. And one of the things that the center is really trying to advance in partnership with other colleagues around the country and other entities, including the National Association for Community Health Workers, the Penn Center for Community Health Workers, and other like-minded initiatives, is to really think about what does sustainable financing look like to support a workforce that is predominantly composed of ethnic minority or minoritized women. So we think a lot about sustainable changes in policy and practice in that realm of supporting community health workers, but we also think about it for other policy-related initiatives too. A lot of the things that we draw upon include an overarching focus on community-based participatory research and practice. And so I mentioned before, what these 3 aims are. So this slide kind of provides an overview of the activities within our 3 strategic focus areas. And that would be stakeholder or community engagement, which is actually the area that I focus on helping to lead in the center, research, and then training and education. And so here you see on this slide some of the leaders who are leading various cores within the center. I just want to highlight Reverend Deborah Hickman, who is the CAB co-chair. She co-leads the Community Advisory Board with Dr. Cooper, and I help to kind of spearhead the work of the Community Advisory Board as a part of the role that I play in the center. So let me just give you a kind of a brief timeline of the Center for Health Equity. So we start in 2010, where the center was established with a program project grant that was initiated and funded by the National Heart, Lung, and Blood Institute of the National Institutes of Health. And through the creation or through the formation of that cardiovascular center, which the focus was on center to eliminate cardiovascular health disparities, they essentially created a transdisciplinary research center that focused on reducing cardiovascular disease, morbidity, and mortality, and improving quality of life, as well as experiences of healthcare for essentially minoritized communities, whether they're African Americans, members of the Latinx or Latin American communities, any community that was affected by disparities in Baltimore City. And so it was, as I mentioned before, a cross-disciplinary team, and it composed faculty, staff, and trainees from a collaboration of the three Johns Hopkins Medicine Institutes, the School of Medicine, the Bloomberg School of Public Health, and then the School of Nursing. And other partners within the Hopkins enterprise were a part of those efforts as well in terms of the partnership. In terms of what was achieved in that year, that first year of the center's existence, there were 3 multi-level intervention trials that were launched: the Project Red Chip trial, the ACT study, and the 5+ nuts and beans for kidneys. This also led to the establishment of our Community Advisory Board and the establishment of other types of forms of infrastructure to support training and research. Then in 2015, we were awarded a $12.2 million grant from NIH and PCORI to conduct the Rich Life trial. The Rich Life stands for Reducing Inequities in Care of Hypertension, Lifestyle Improvement for Everyone. And as an aside, I played a role in helping to formulate the interventions that made up the collaborative care intervention. Then in 2016, Dr. Cooper was recognized as a Johns Hopkins Bloomberg Distinguished Professor. But another wonderful thing that happened was that the deputy director of the center, Dr. Deidre Cruz, was awarded an R01 from NIMHD, the National Institutes for Minority Health and Health Disparities, to essentially expand upon the 5+ nuts and beans work that was done 6 years prior and extend it to kidneys. And so in 2017, we actually changed our name to the Johns Hopkins Center for Health Equity because we were broadening, and we were in the midst of broadening and deepening various collaborations. We were addressing various social determinants of health and health conditions, and we were expanding our scope of impact in terms of engaging with several socially at-risk, vulnerable, and socially disadvantaged groups in the United States, as well as across the African and Latino diasporas around the world. And so we also then in that time launched our first degree level course, Applications of Innovative Methods in Health Equity Research. We also received funding in 2018 from the Johns Hopkins Alliance for a Healthier World to conduct what is called the Addressing Hypertension Care in Africa, or ADRINCA study in Kumasi, Ghana, as well as co-sponsoring multiple symposia. For example, the Fierce Urgency of Now, which really centered on uplifting the memory and legacy of a beloved colleague for many of us in the center, Dr. Shalon Irving, who passed shortly after giving birth to her first child. And so the fierce urgency of now is really focused on elevating the importance of Black maternal health. The other thing that we were proud to play a role in supporting was the 1619 to 2019 project or symposia on the legacy of slavery for health equity in Baltimore and beyond. And then in 2020, we launched our second degree level course, Local and Global Best Practices in Health Equity Research. The other thing I just want to make note of is that last year in 2021, we were fortunate to receive a grant to be one of, I think, 10 or 15 P50 funded centers through the National Institutes for Minority Health and Health Disparities, focused on addressing cardiovascular disparities. And so we are in the midst of formulating all of the different studies programs, as well as the community engagement strategies that are underway. And I am co-leading those efforts for community engagement with Reverend Deborah Hickman. So now you're aware, and this slide is a little bit old, so it's no longer forthcoming, but you're aware of the book that Dr. Cooper wrote, Why Are Health Disparities Everyone's Problem? And I think what I personally appreciate about the book is the very personal lens that she adopted in terms of talking about her upbringing in Liberia and how it played a role in shaping her career as a physician scientist. And as you may know from having read the book, when she draws upon these experiences, she is also linking it to these broader themes around the roots and nature of health disparities, how differences in communication and the quality of relationships affect health outcomes, and different actions and policies that we all need to adopt to consider how to reduce and eliminate conditions that are harmful for all of us. And so I'll just close by sharing what our vision is. And we've kind of seen how important this philosophical orientation is throughout this pandemic period, where we have become, well, some of us were already aware of it. Many of us, I'm sure in this group, are already aware of intransigent health disparities. And now we're wanting to shift to health equity. So no longer focusing on, well, not to say that we're no longer focusing on health disparities, but that we're really expanding our horizons to encompass a lens that embraces health equity, defined as when every person has the opportunity to attain his or her full potential or their full potential. So this is the last slide in this particular deck. And here's some information about Dr. Cooper, about the Center for Health Equity's website, and following us on social media. So I'll stop there if there are any questions about the center and about additional things that you may want to discuss.
Thank you so much, Dr. Ibe. Do we have anything in the chat, or does anyone want to come off mute with any questions?
I do have a question. Actually, I was wondering how to contact the people at this center, or even Dr. Cooper, really, because I had just mentioned, I think before you arrived, that we are revamping one of the classes in our collaborative practice course. And this is a course for all the different health professions, education students, and they're in teams together with different health professions. So we were talking before you came about structural competency, and we would like to have sort of case studies, but clinical case studies of patients with health issues that are a major challenge in Cleveland, which are probably the same ones as in Baltimore. Infant mortality and Black maternal health and lead poisoning and cardiovascular disease. And I particularly was interested in the case that was in the book that was in the story called 5 Miles Apart. And it talks about the woman who, they both had cardiovascular disease, but the outcomes were dramatically different, partly from where they lived and all sorts of historical and structural elements. And we've been desperately searching for cases like that. So I was going to contact someone at the center or Dr. Cooper herself and ask permission to use that case in our course, albeit it's Baltimore, but it's almost identical to Cleveland. I just wondered, who would I contact to get permission to use that?
Yeah, I'll share the last, oh, it doesn't have her email address. So I think one of the things that you could, let me just share this last slide.
Yeah, I put the healthequityhub.org, but I didn't know if that was the right one to write to.
Yeah, that's the Center for Health Equity's website, but you can also email healthequity@jhmi.edu. And I believe the email will be forwarded to her.
Okay.
And I can also, if you send me an email, which I can put in the chat, I can also help facilitate.
Oh, that would be terrific. Thank you so much.
You're welcome.
It was just as soon as I read that case, I thought, wow, this would be perfect for our class. And but now we're in search of things like lead poisoning and the infant mortality cases, and so far I have not been successful in finding any.
Could you walk us through your engagement process? In the text, it talked about, so it had 3 stages: intervention planning, implementation, and dissemination efforts.
Mm-hmm.
If you could maybe touch on those with an example.
Sure. And you're asking how that fits in the context of how we employ community engagement across that trajectory. So yeah, actually, I have a very recent example, a fairly recent example. I had mentioned towards the end of the presentation that we recently received another P50 funding mechanism type of grant. And when the grant was first announced, what we did was that we pulled together our community advisory board. So our community advisory board is made up of about 45 to 60 members. And the reason it's a fairly large range is because some people come in and out depending on their availability. And it's multi-sectoral. So we have a number of partners who work with the Baltimore City Health Department, the Maryland State Health Department. We have community members who are part of the CAB, community health workers, nurse case managers, physicians, health system leaders. So it's a very, fairly representative group of individuals who have a vested interest in health equity and have delved into issues around health equity and health disparities through their work. And we also have people in the CAB who are actually not engaged in those areas. So when the funding announcement came about, we wanted to make sure that we were responsive to the announcement in a way that was aligned with the goals of the overarching goals for the Community Advisory Board. So we pulled together a meeting, and we had the investigators who had specific topics that they were interested in writing about for this grant meet with CAB members in breakout groups, and they would kind of vet their ideas with members of the Community Advisory Board. And together they refined what the intervention components would be that would be subsequently proposed for this funding mechanism. Then what ended up happening was, we were fortunate to receive the funding. And I will even say for the Community Engagement Corps, we employed a really similar strategy. So within this particular funding, they're basically standing up community engagement, education and training, and then 3 randomized trials, as well as an administrative core. So with the Community Engagement Corps, although I was the lead for writing that grant, it was reviewed by Reverend Deborah Hickman, who is now the co-chair, and it was also reviewed by another member of the Community Advisory Board, who is actually now a co-investigator in the Community Engagement Core for this grant. So, so that is what it looks like in terms of intervention development. Well, intervention conception and intervention development from the standpoint that now that the funding has been received, we've set up a mechanism whereby all of the study teams are supposed to be working with what we call community coordinating councils. And basically, these are individuals who are stakeholders and potential community partners. And I say potential because some aren't existing partners with these individual study teams, and some are newer partners of the study teams. So they're in the midst right now of developing intervention components and meeting with members of their coordinating councils to just get a sense of the degree to which they're on the right track, if things need to be modified, how to adapt certain intervention components in a very contextualized manner that is attendant to the different social determinants of health that are affecting that particular area, that particular geographic area that the intervention would be implemented in. And we're not at the dissemination phase yet, but I believe that some of the teams have started to think about what dissemination looks like. And then from the perspective of, as a co-lead for the Community Engagement Core, we're also focused on building institutional capacity within this P50 mechanism to conduct community engaged research. And so to that end, members of our Community Engagement Core are serving as community engagement advisors to these teams. So we're pairing off. So myself and another faculty member are working with the Healthy for Two project, which is geared toward reducing obesity among Black and Latina or Latinx persons who have given birth. There's another team with Reverend Hickman and Dr. Cooper, who are the community engagement advisors for the unload heart failure. I'm sorry that I don't remember what unload stands for, but it has to do with cardiometabolic health. And then finally, there's another study, the linked hearts. There's actually two linked studies funded by that the two PIs are leading, and I always forget which one is which. And that one, the community engagement advisors for that particular project are a professor in the School of Public Health and Miss Michelle Simmons, who is the community member I mentioned earlier, who is a co-investigator. So we really try to embed community voices within the fabric of the studies that are being done. As another example, I'm co-leading a study right now with a very close friend and colleague that is also within the Center for Health Equity. And this is a study that is trying to address adverse social determinants of health at a family level at a pediatric clinic. So we have built into the budget collaborative partnership building with different entities at Hopkins, but also in New York City, which is helping us to co-develop this intervention. And we have a community health worker who is essentially a co-investigator on this team as well. So, in all of these various projects that I've mentioned, we think very critically about, again, embedding community voices or uplifting the lived experiences of those who kind of are directly affected by some of these issues. And I see in the chat your question regarding whether or not do you believe houses of worship are the best places to promote health in a community? I personally don't think they are the best places, but I think that they are a great place to initiate such discussions. And the reason I wouldn't go so far as to say that they're the best place is because increasingly, societally, people are not going to places of worship as often as they used to. And so we need to really be creative and think outside the box about what it looks like to meet people where they are. So institutions of our faith-based institutions are a great, they are still and will likely be for many years a great place in terms of thinking about partnership and, capacity building within those institutions to address issues related around health. But there are other types of entities or organizations that could be ideal too. Here in Baltimore City, Baltimore is a city of neighborhoods. So I'm not sure if Cleveland is similar in that way, but Baltimore's neighborhoods, many of them have their own neighborhood associations. So we've had opportunities to go to neighborhood association meetings and just learn what people's concerns are regarding health and wellness, and even to just start to build those bridges so that if opportunities emerge that they are interested in pursuing, they know that we are a resource to help address, help them attain either funding or additional support to kind of realize whatever vision they have. So I hope what I said answered both questions.
So I'll read this one out loud if you'd like. How can we elevate the conversations taking place or that need to take place regarding equitable compensation for community members involved in research? So from participants to community advisory boards and beyond. And really, and we started this conversation earlier on in the meeting, and the coercion, it's something that is a concern. At the same time, we're not offering life-changing money. Like, you won't be a part of a cab and then be able to buy a mansion in the hills somewhere. So how can we just elevate that conversation and take real action that shows that we value everyone who's at the table?
Yeah, that is a really critical question. And that's why I started smiling, because I don't fully know the answer to it. I will say that it's a very timely question in the sense that the consortium of studies that are part of this NIMHD funding mechanism, we have those of us who are co-leading or leading the community engagement course in these respective institutions or these respective sites. We've been having some discussions about what that would look like, what our recommendations are, for example, around compensation for CAB members or for any community partner. I think there are a couple of things that come to mind. The first is, I think we need to be honest about the reality, and frankly, kind of the sad reality, that as long as the funding mechanism favors academic institutions, there's always going to be a disparity in terms of equitable compensation for community members engaged in research. And, I say that because with this particular funding, it was, all of the institutions that were funded were major academic health centers. They didn't fund community-based organizations. So it's left to these academic health centers to allocate monies from that budget to give directly to CBOs. And that there are there's a lot of red tape, bureaucratic red tape associated with that. So I think some of this is going to involve advocacy on our parts to really have meaningful conversations with whomever is making these decisions. So that's one thing in terms of elevating the actual conversation itself about this topic. From a practical perspective, the way that we've tried to get around it is to actually include community members as co-investigators, because in that way, we're amplifying the reality that their lived experience is just as valuable as some of the experiences we have that were conferred by training. And it's not to suggest that some of us don't have our own lived experiences, but my experience as a doctorally trained public health researcher are not quite the same as that of my community health worker colleagues, as an example, or of the patients who have been involved in the trials that are housed within the center. So in order to really acknowledge some of the disparity in power in terms of whose voice gets listened to the most, we're trying to kind of create a more horizontal structure in terms of power and in terms of decision-making by including community members as co-investigators. And so far it has worked. And Rebecca, that's an excellent question. Have you found or developed a simplified process to integrate community members as co-Is? We struggle even to get them through the initial credentialing process. I was just curious what you mean by the latter part. The credentialing process?
Sure. Well, I work at UH Rainbow, and anybody who's a part of our research has to go through, has to be research credentialed at our institution. And so as we're kind of in the mix right now, we just worked through our first true community researchers, getting them credentialed to be part of our IRB approved projects. But I would say it took an astronomical amount of time for me to sort of usher them through that process. Everything was out of policy because they're not affiliated with any of the institutions. Legal had to be involved, the compliance department was involved. And our concern is that we've created, or we sort of exist in this sphere, as you talked about, like with the academic lens, that I know we're trying to protect participants of these studies, but but in order for us to have diversity on our research teams, we've got to create a more feasible process that's realistic, because we've asked these community researchers to dedicate dozens of hours even before they can be considered part of the research team, to do their city training, to complete background checks, to do additional online trainings. And we're trying to think about how to create a roadmap ourselves, because I think that without somebody, I sit in sort of like the back office support, and so I'm providing them with some sort of administrative navigation, I guess you might say, through all of these processes, but I don't know how many other PIs would be willing to provide that kind of support. And my concern is that we'll lose the opportunity if we don't simplify or streamline enough that people can be a part of the process and not feel like it's such a high hurdle to clear just to get in the door, whether that's the PI or the potential community researcher or both.
Yeah, I think, I see the point that Jackie, I hope I pronounced your name correctly. She mentioned that there's been some work nationally from PCORI to push back on IRBs. And I think I agree with what she said, because I've been aware of those efforts myself. And, Rebecca, I'm struggling to answer your question, because I think some of it is really institution dependent. Hopkins, we have our own set of hurdles to climb when it comes to this issue. So for example, in order to be listed as a co-investigator on an IRB, a community partner needs to, complete city training. But in terms of being regarded as a co-investigator, they don't have to complete such stringent, there's no such set of stringent requirements when it comes to them actually being designated as a co-investigator. So I wouldn't say that we've developed a simplified process. I think that the process was already there. And so, we're fortunate to not have too many barriers in terms of having community members as listed as co-investigators or designated as co-investigators. But now that I think about it, at Hopkins, they would certainly have to complete the city training. I don't know if they would have to undergo a background check. And as an aside, that can be very challenging depending on various communities that have been over-policed and over-surveilled. So, it just leaves out a lot of compelling voices when that is a requirement. So I wish that I knew the answer to that question, except to say that I share your pain from the standpoint that, as Jackie mentioned, a lot of these academic institutions really struggle with having an infrastructure that's conducive to community engaged research. And the IRB is one of the mechanisms by which we unfortunately leave a lot of people out of the research enterprise. And I'm not sure the best way to address that, except if more of us are actually on IRB teams and help to shift policies that are favorable towards this type of work. But I hope that kind of helps in some way. And I think it's wonderful that you've undertaken so much effort to, work with people and get them involved in the work that you and your colleagues are trying to do.
That's really helpful context. And I think it's a good reminder that we need to reach out to other institutions to kind of get maybe a better understanding of the landscape of how other places do this, because I think sometimes it's like we've only done it one way, and I'm talking like we as a larger system, and if maybe there's a way to say, but look, this works at Johns Hopkins, or this works someplace else, and this is a way to maybe navigate the integration of community researchers, and the sky didn't fall. There wasn't a data breach. There wasn't, that like level of acceptable risk versus the unintentional consequences of not having a more diversified research team. I think are really important considerations, and we probably need to do a better job of building the case around that.
Yeah. Well, you have my email, so if there's anything I can do to help, please feel free to reach out. And I think what Jackie said is that looks really wonderful too, developing a community guide.
So I think sometimes in Cleveland, and I don't know if it's like this in Baltimore, but we are so notorious for being siloed even across town on what one another are doing, even within the CTSC, even within Case Western. So this is something that we developed, probably, 8-10 years ago to help our community researchers and partners get through some of those, mandatory things like crack and city certifications that they can be on board, but do it in community friendly fashion. And the other thing I'll say, Rebecca, I know just having some other folks have to get on board. UH is extremely notorious for their onboarding process. We've worked with HR to try to streamline this because needing to be on the IRB, but depending on not needing such a threshold. And so just starting those conversations with your HR department about do we really need a background check? Do we really is there another path for some of these community-based researchers so that they can be on IRB and through some of the maybe modules and onboarding, but not as rigorous as maybe a full-blown employee. So I would encourage you. I'm happy to talk more about that as well as what we've been trying to do at Metro Health.
That sounds great. And I do want to just say, Hopkins, when you asked if things are siloed here, that is absolutely the case. And so it's a constant battle.
Well, thank you so much, Dr. Ibe, and everyone who has joined us for week 5. This has been a phenomenal conversation. And as you said and noticed, everybody who's in this room is currently doing this work in some form or fashion. So this has just been incredible. We really appreciate your time, talents, and expertise. And with 1 minute to spare, I hope everyone has a great afternoon, and we'll see you next week.
Thank you so much for having me and for being so gracious with my mistaken date.
Absolutely.
Take care.
You too.